The health and medical information provided during this webinar, as well as the questions and responses from the webinar providers, are solely for informational purposes. This content is not intended to take the place of advice or treatment from health professionals. Nothing presented in the webinar is intended to be used for medical evaluation, diagnosis, or treatment. It is not intended to substitute for your relationships with your own healthcare and pharmaceutical providers. Always seek the advice of your healthcare provider before beginning any new treatment, or if you have questions regarding a medical condition.
Really appreciate MedMD inviting me to talk to you guys tonight, and really appreciate all of you for taking the time out of your evening to join me tonight to talk about something that is an area of patient care that I'm very passionate about, which is, erectile dysfunction and male stress urinary incontinence as it does or does not relate to prostate cancer. So we're going to go through kind of our basic presentation here, and certainly if you have any questions, feel free to submit them into the chat box, and we will have time at the end to go through questions. So without further ado, erectile dysfunction, or ED as we will abbreviate it, is defined in a number of ways, but the most common definition is the persistent inability to achieve or maintain an erection that is firm enough for sexual activity. So, we want an erection that is satisfactory for sexual activity. And while certainly this is not something that as your average guy we like to talk about on the street, it is very common. It's present in 1 in 5 men aged 20 and older. 1 in 5 suffer from some degree of ED. And more importantly, as men progress over 40 years old, it's present in about half of men, which is a really staggering number to me. So when we talk about the erection, we see the erection in our day-to-day lives, but what we may not all think about, but I do as a sexual medicine specialist, is what it takes for that erection to actually work. So in order for erections to work, there needs to be some sort of stimulation or arousal, something that gets us excited, right? And this triggers the nerves of the penis to become activated, which allows for muscle relaxation around the penis and increased blood flow to the penis. The additional blood causes the penis to stiffen, and if you could see my mouse, you'll see that these red cylinders are the muscular bodies, and this is what blood is flowing through, and then as it compresses against this layer surrounding, it causes the erection to stiffen. So, why do people get erectile dysfunction? And, the biggest thing I would tell all of you is there's no single one cause that leads to erectile dysfunction. There's many different issues, but by far and away, the things we know that contribute the most are increasing age, smoking, diabetes, and hypertension. And hypertension is high blood pressure. By far, those are the biggest predictors. There are other issues. We know that mental health, depression and anxiety can play a role, as well as obesity can play a role as well. We always talk about in my practice, what's good for the heart is good for the penis, and that's because the blood vessels that supply the penis are much smaller than the heart. So if we're making healthy life choices or we're not making healthy life choices, those things are going to affect the penis before they affect the heart, since the blood vessels are so much smaller. But one thing I really like to focus on with my patients is that, while ED is technically a medical issue, this is, if we take a step back, just kind of daily life, factors, this is a important thing that deeply affects both individuals and their relationships in real life. And this is echoed by the fact we have fairly good research studies that show that men who experience ED are more likely to experience anxiety, depression, self-esteem and self-confidence issues, as well as an overall impact on quality of life. And, this can be a problem when it's causing us to pull away from our partners and affecting our personal relationships. So, I would encourage you, if this is something that applies to your life, to think about this as we're talking through this lecture today, and, how we may be able to improve this for you. For erectile dysfunction, so the good news is there are a lot of different treatment options, right? And so the first question becomes, well, who should I see to talk about erectile dysfunction? And there's a variety of different people who can help you with this. The first would be, your primary care physician, right? So we see our primary care providers for a variety of things, and typically primary care providers are willing to at least trial you on a medication called a PDE5 inhibitor, which we'll talk about more. This would either be like a sildenafil or a tadalafil, but that's really where their treatment kind of ends and where our role as urologists pick up. So, there's many urologists out in the community, and a urologist is a doctor. So I am a form of a urologist. We have specialized training, surgical training that focuses on surgical and medical issues of the male and female genital urinary tract. Where my role comes into play, so as a fellowship trained urologist, I am what we would consider a prosthetic urologist, which is somebody who's had additional training in advanced men's ED and urinary incontinence, which we will talk about as well in this talk, and specialize in implant surgery to help men regain their function. So to go into treatments a little more, starting from the left and moving to the right, we have a variety of treatments. And the biggest thing I want to tell people is that, this is when people come into my office, this is a shared decision-making process between me and my patient, and not each one of these, no single option is the perfect fit for each patient, right? And certainly you don't have to try, all of these options before choosing, like if you want to go to a penile implant, you don't have to try all these other options. However, we do find that most patients progress along this pathway. The first option would be pills. So again, like I said, this is a tadalafil or a sildenafil. The commercial names would be, Cialis or Viagra. And they work well for people, with mild to moderate erectile dysfunction. The next option, and what is often used in conjunction with medications or injections, is something called a VED, or a vacuum erection device. And this is where essentially there's a constrictive ring, as you can see by this red portion here, that goes around the base of the penis, and then we use a vacuum to draw the blood into the penis, and the band keeps the blood in the penis to maintain that erection. This is good for people who are able to get an erection, but then maybe have trouble maintaining that erection. This can certainly help with that. Next, we have injections, or what you may hear called ICI, or intracavernosal injection therapy. This is a combination of several medications, anywhere from 2 to 4 medications that are very potent. And every time you want to have an erection, you take a very small needle. If you're diabetic, think about a diabetic needle, and inject it into the side of your penis to obtain an erection. And last but not least, the area that is a focus in my practice and how I help the most gentlemen is with the penile implant surgery, which we'll talk about here in a minute. So again, the medications, they are available. They're easy to get in the United States. They do, work fairly well for people with mild to moderate ED. Commonly, the side effects can include things like headache, facial flushing, GERD, so acid reflux, that can happen. The biggest thing is that if you have a heart history and you're taking a medication called nitroglycerin, you cannot take this medication as it may cause your blood pressure to drop very low. So something to consider there. And, we like to highlight that, certainly men who have diabetes, there was a really nice study done looking at 20,000 men with ED, and men with diabetes were about 1 to 2 times more likely to move on to other treatments. And this kind of shows that folks with diabetes, the nerves and the blood flow has already been affected in a way that medications sometimes cannot salvage for patients with diabetes. Next, we have the VED. Again, we talked about, the fact that this is essentially a pump which brings blood into the penis, and then there's to create a vacuum effect, and then a tension ring is placed around the base of the penis to keep blood there. It works well for some people. However, it can be quite uncomfortable for patients and their partners. It can sometimes interfere with ejaculation, as it is compressing the urethra to some extent. However, if it's positioned appropriately, this is typically not a big issue. And, you know, the most common reasons for discontinuing this therapy is pain and discomfort. Next, we have injection therapy, which I do utilize a lot in my practice. Like I said before, it's an injection-based therapy that goes in the penis, and it does work well. It's very potent. The biggest reason that patients discontinue this is that, you know, it's kind of inconvenient. It can be inconvenient to use. It's not covered by insurance, so depending where you live in the United States, it can be pretty costly. And a lot of my patients just tell me that it kind of kills the mood with their partner. You know, the time arises to be intimate, and then they have to go to the freezer, get the medication, and inject themselves, and then wait for it to work. Nobody wants to really wait on that. So it can be a spontaneity killer. We did actually do a research study with our own team looking at men, you know, who go on this injection therapy, and at a year, only about 35% of men were still using this therapy and had progressed to another treatment. So certainly worth trying, but has a very high dropout rate. And last but not least is the penile implant surgery. This is an outpatient surgery. In my practice, you come in, you get the surgery, and then you go home the same day. We'll show more videos about how this works, but essentially it's two inflatable cylinders that go in the penis through one incision in the body, usually below the penis. If you can see my mouse right here. There's a pump that goes in the scrotum that you cannot see from the outside, somebody looking at you. You pump the device up using this reservoir. This sits in your belly. You do not see or feel this, and it cycles fluid into the device to give you a rock hard erection for sexual activity. Out of all the options, this does have the highest patient and patient partner satisfaction rate when comparing meds to injections to surgery. Typically, the implants that I use are with a partnership with a company called Boston Scientific. We use a device called the AMS 700. There are various models of this, and this is something I discuss with my patients when they come to see me about which model may be right for them. A lot of this decision making is made in the OR based on measurements of the individual patient. So these are implanted on a custom size basis per patient. What is special about this device and why I choose this device a lot, this device is coated with a proprietary solution called Inhibizone, which is basically a mixture of antibiotic therapy. It helps reduce infection rate. It does very nicely mimic both flaccid and erect penis. So somebody looking at you really would not know you have one of these surgeries. It does provide a very rigid erection, which allows you to get the job done and be intimate with your partner or with yourself, whatever is your goal for that time. So I'm going to play this video and I'm going to talk you through this. This is a cartoon of how this device works, and then we'll have a real life video to show you as well. So this is just the general disclaimer for the video. So as you're seeing, you're looking at the patient. The two cylinders are in the penis, as you can see. The patient squeezes the pump, and as the arrows suggest, that cycles fluid from the belly into the penis and makes a rigid erection. You then are able to use it for as long as you would like. When you're done, you squeeze the button on the pump, and then that deflates the penis, and it looks like a natural soft penis once you're done deflating it. So pretty simple concept. Now we're going to look at what this looks like in a real patient. This video footage was provided by one of my colleagues, Dr. Cartman, who is in California, and it's one of his patients who graciously, decided to provide footage of this to help other men. So as soon as this disclaimer goes, you will see the video, which shows how it works. So you can see the patient squeezing the pump, and he's inflating the device right now. You can see as he pumps it, pretty easy to pump, not hard to use. And as you can see, that's a very rigid erection, very functional, looks and feels like a natural erection. Then when he's done, he's going to squeeze the pump. And yep, you can see him holding it there. He's going to squeeze it. You squeeze it for about 3 to 4 seconds. That will deflate the penis. And then typically what I tell my patients to do to get the last bit of fluid out and make it really look like, a flaccid penis is to give the penis a gentle squeeze, and, that will make it look, flaccid. This is not painful to do once patients have healed, and it becomes very second nature for people. So to go over what to expect for a potential surgery, this is done as an outpatient basis. Surgeons do this surgery through 2 different incisions. So I use what's called a peniscrotal approach, which is an incision. If you find kind of the underside of your penis where it meets the scrotum, that is where my incision goes. There are surgeons who use what's called an infrapubic approach, which goes kind of right above your penis, near your the pubic kind of bony part of your pelvis. They both work great, and it's entirely surgeon and patient preference. But all components that you saw in the video go through that incision, and it's usually about 2 to 3 centimeters. The procedure is performed under general anesthesia, and like I said, typically, depending on your surgeon, they will tell you no lifting over 10 pounds for about 2 to 4 weeks. That's pretty standard. And then typically your surgeon will teach you how to start using this at 4 weeks with the permission to use the device for sexual activity for 6 weeks. Or at 6 weeks, excuse me. We want to provide enough time to let this heal, so that way it's healed well and it's not painful for you. So, I get a lot of questions about this, about cost and coverage. And, the really great news is that the grand majority of insurers, ranging from Medicare to private insurance, all accept that this is an important issue for men's health, and it is typically covered by insurance. Certainly, anytime I have a gentleman who is interested in this surgery, the first thing we do is run it through insurance. And if there are any issues, we're able to usually appeal it and get it covered. But that would certainly be based on your individual insurance policy and kind of what's going on, in your local region. There are also sometimes financial assistance programs that can help cover out-of-pocket expenses as well. This is a video I like to show. This is a patient who has received a penile implant, and it's just kind of an attestation to, his experience, about receiving the implant. So it's a very short video. We're going to go ahead and play that.
It's a general improvement in my whole emotional state, and I wish I'd have been quicker about it and more proactive. That is my one regret about the whole thing, is that I didn't get it done sooner. So don't hesitate.
So, it's a short clip, but I hear that a lot among my patients. I mean, obviously, even an outpatient surgery is, it's not to be taken lightly, but the surgery does take about 45 minutes. Patients do great. And, patients are very thankful to be able to get back to their intimate life and not, have to wait around for meds to work or for injections to work. The patients enjoy it. It gives you back your spontaneity of life, and it does have the highest partner satisfaction rate as well. So, I have a lot of patients who echo the sentiments of Andy here in this video. So, you may ask, and very appropriately, so, okay, great, I'm interested in this surgery. What are the risks? So the biggest thing with this surgery is, while we don't need to try all of the therapies to do this, it is technically an end of the road treatment option. And what that means is that once an implant goes in, your erections will be dependent on that implant. So, if for whatever reason that implant were to be removed, you will not obtain spontaneous erections again. These devices have been made for a really long time, and they're made very well. Nonetheless, it is a device, and there is a risk of mechanical failure. We quote people that receive penile implants that over 10 years, the chance of mechanical failure is about 5 to 8%. So it's pretty low for even a 10-year period. And even if there is a mechanical failure, the fluid in this device is normal saline, which is salt water, essentially. So it's not like, like a breast augmentation or something else like silicone, where if it spills out in your body, that needs to be handled right away. This is a safe fluid that will not harm you. The most feared complication is infection. If you've ever had orthopedic surgery, like a total knee or a hip replacement, orthopedic surgeons are very worried about infection, and that's because it's a foreign material that's in your body. And if there is an infection, the device would need to be removed. The device infection rate for most surgeons who do this surgery a lot, like myself, is very low. It's about 1%. However, we mitigate this or prevent this by giving antibiotics preoperatively as well as postoperatively as well. So very important to know that that is our biggest risk. What I would tell you before we switch gears into the continence realm of things is that, I tell a lot of my patients that you truly are not alone in this. This is something that is way more common than I think we as men talk about. And our industry partners have a website called edcure.com, which is excellent. And there are opportunities to speak to patient liaisons about this procedure. So if you're thinking like, well, this doctor is giving a talk about patients and he's showing these videos of patients, that's great, but I want to talk to somebody else, there is an opportunity to get linked up with a patient advocate who has gone through the experience and can talk to you about what it was like for them. These are just some basic disclaimers about kind of found on the box of the device. These are available online, so I'm just going to kind of click through these, but basically it talks about the material made in the device. And while they are well made, there is always the chance of infection, which again, very small. Next, we're going to switch gears to the other part of my practice, which is treating male stress urinary incontinence, or SUI, as we'll call it. This is a website that I refer a lot of my patients to. I'll give you a few seconds. If you have your cell phone, you can scan this QR code and visit to kind of learn more about this. So I'll give you about 10 seconds to do that, and then we'll move on with the PowerPoint. Okay. So male stress incontinence, what is this? So incontinence in general means involuntary leakage of urine when you don't want that to happen, right? There are different types of incontinence, and what we're going to specifically talk about today is stress incontinence. And this is the leakage of urine when pressure is put on the bladder, causing leakage. And so what I always ask patients is, do you leak urine when you cough, laugh, sneeze, or when you're active? Going for a walk, running, lifting heavy. It's actually pretty common. It affects 13 million men worldwide. And we know that at least in the United States, about 17,000 new men per year will develop bothersome SUI. So the way that this works is as if I were looking at you, the patient, from the side, right? So I'm standing on the side of you and looking at you. The bladder is what holds urine that comes from your kidneys up in your belly. The prostate surrounds the urethra, including the prostatic urethra, and this is something we will talk about much more. And then the sphincter, this is a muscle in our pelvic floor, the external urethral sphincter, that helps prevent leakage of urine. So this is the sphincter that's under voluntary control, where if you have that sensation, I really have to pee, but you're not at the toilet, this is kind of where your brain is telling you to hold it, and that's what's at play. And then this is the urethra, which runs through the penis. So there's different causes of stress urinary incontinence, but the one that I see the most in my practice, and what I think is most relevant for this talk, is men who have prostate cancer, who have had a radical prostatectomy, and even with radiation, this can occur as well. So what can happen is that external sphincter can become compromised when the prostate is removed or the prostate is radiated, and that can impair the ability of that sphincter to hold in urine. So, I see, having treated both sides of the coin, the ED as well as the continence, these are both big quality of life issues that affect my patients. But I will tell you that most of my men who deal with both issues tell me that the urinary, while erections are very, very important, to them, the urinary incontinence is way more important. And, I think that's pretty common sense. Nobody likes to be leaking urine or wearing pads or, Depends just to be able to go out in public. So I do find that this is a big quality of life factor for patients, and it is very much linked to developing depression and anxiety, especially social anxiety. And that does get worse with severity. So how is this linked to prostate cancer treatment? So, currently in the United States, approximately 90,000 radical prostatectomies are performed each year. And while we counsel people and while techniques in surgery for prostate cancer are getting much better, we still see short-term leakage in a lot of patients. So most of my partners who are doing prostatectomy surgery will tell their patients that for the first couple weeks, they will certainly leak urine. But with pelvic floor physical therapy, which we'll talk about a little bit, and time, most men are dry, meaning not leaking urine, by 1 year. However, still about almost 10 to 15% of men are still having residual urinary leakage, stress urinary incontinence at 1 year post-treatment. And so the reason why this happens, this is kind of a picture, this is a prostate that has some cancer in it. That prostate is being removed. And essentially when they do that, your surgeon will have to sew the bladder back to the urethra to do this. And we do this in a way typically that spares the sphincter, the external sphincter. But sometimes depending on the degree of the cancer, the location, the nature, this can impact the nerves that affect the area, and it can affect the pelvic floor. And, sometimes people do have residual leakage from that. So the question is, how do we treat this? And unfortunately, unlike our erectile dysfunction side of things where we have lots of medications and injections, we don't really have that on the stress incontinence side of things. So, we start with behavior, we talk to people about behavioral changes. So, we don't want people not drinking anything at all, but certainly the more fluid they drink, the more pee they will make and the higher chance they have of leaking. We also talk about planned restroom breaks before they even feel they need to go. So if you're peeing every 1 to 2 hours, you're keeping your bladder empty, less chance that it's filling a lot, and then less leaking. That works mildly. But usually that's not enough for patients. In terms of interventional things, so the biggest thing that I have a lot of my gentlemen do is pelvic floor physical therapy. We have them see pelvic floor physical therapists as well as practice the exercises at home in the form of Kegel exercises. This can help really strengthen that pelvic floor, strengthen the musculature, and kind of help support that urethra and prevent leaking. We also have patients concomitantly using pads, Depends. There are certain catheters called condom catheters that can go over the penis. These are things that most people are unwilling to live with for the rest of their life, which I think is very reasonable. So there's 2 surgical options. Again, these are outpatient surgeries. We have 2 options to treat, gentlemen, and a lot of this is dependent on how severe the leakage is, which can be defined in a number of different ways. The best treatment for mild urinary incontinence would be, the male sling. And this is minimally invasive, done through a small incision in the perineal region, and it helps to provide support to the urethra that has been lost from surgery. So this is a picture of it. This is as if you are laying down on a bed and your feet are facing me as the doctor. This sling is going to wrap around the urethra right here, and when it's pulled up, it supports this urethra to provide tension against it and help minimize leaking. Think of it as a hammock, supporting the urethra. Overall, pretty high satisfaction rates, about 80 to 88% of patients when they were surveyed in a study would recommend this procedure to a friend. The more significant, not significant, but the procedure that we use for more severe urinary incontinence, this is people who typically leak more than 2 pads a day, leak and soak more than 2 pads a day, is the artificial urinary sphincter. And this has always been considered the gold standard for male SUI treatment. And, it can treat all levels of stress incontinence, but we certainly reserve this as well, for our patients with really severe incontinence. It is a device similar to the penile implant. It is operated by you, and it does require manual dexterity to work this device, and we'll look at why in a second. So essentially what we're seeing here is this device is, think about it similarly to the penile implant. Again, we do a small incision in the perineum, which if you find the backside of your scrotum, it's down in that region. Through that, we place this cuff around your urethra. There's a pump that goes in your scrotum, and then a pressure regulating balloon, or PRB, which goes in the similar place as that penile implant reservoir goes. And what happens is, you know, this cuff at baseline is closed, and it's not, it's obstructing the urethra so that you do not leak. When you press this pump, what happens is it regulates fluid, and it allows this to not contract as much, and then the urethra opens and you can pee. And we should see a video of this here. So I'll walk you through this here. All right, so general disclaimer. So again, the pump is usually in the left or the right side of the scrotum. And what you're gonna do is you're gonna cycle the device by pressing the pump. Fluid will leave the cuff, and it will allow the urethra to expand, which will allow you to pee. This will stay open for about a minute, and then it will slowly close with time. All right, so in terms of what to expect for the procedure, it's an outpatient procedure. It takes a small incision in the perineum as well as a very small incision right above your pubic bone to place that PRB. We tell people to take it easy for a few days to allow their incisions to heal. And then again, you know, shortly after the procedure, we leave the device what we call deactivated, meaning you're still going to leak urine as you did before surgery. After about 4 weeks, we activate you. That's been enough time to heal, and that's where you're ready to go and use the device. So, you know, patient satisfaction with this. I find some of the happiest patients in my practice are patients who were leaking multiple pads a day, who we got down to either 1 pad, 1 preventative pad, or even sometimes no pads. We don't guarantee 0 leakage. However, there is a very meaningful improvement for patients, and we see that based on data, you know, in this study. You know, we have very high satisfaction rates. And, you know, even if you look at the right, it talks about published long-term studies show that most patients are using 1 pad or no pads per day after this surgery, you know, even at several years after surgery. So I think that's very meaningful. And, you know, this is an example, you know, of a gentleman, and I see patients like Herschel all the time, you know, gentlemen who've had their prostate cancer surgery, you know, a year out from surgery, they're still leaking a ton. You know, this gentleman had 9 pads a day, and now he's down to 1. You know, it feels like, you know, he talks about how he feels like he has the confidence to go back to his regular life, you know, play with his grandkids or laugh at jokes with his friends and not have to worry about wetting himself, which I think is just, you know, that's not something anybody should have to deal with. You know, risks of the procedures, again, for the AUS, the artificial urinary sphincter, there is the risk of device infection. There is also the risk that over time, you know, 10, 20, 30 years down the road, the cuff, the part that surrounds the urethra, can erode, which would require it to be removed. And then certainly there is the risk of, as all of us as men age, if we, you know, forget that the device is there and we don't have somebody to help us with that, you know, it could lead to your, you know, retaining of urine. And, you know, usually we have people wear like a bracelet for this, similar to like a diabetes bracelet. That way people know that somebody has one of these devices. So in summary, this is a very well-known side effect of prostate cancer treatment, whether you go the surgery route or the radiation route. There are a variety of treatment options. However, most of them are not medical. You know, the sling or the AUS offers great long-term treatment. Would say that if...
Alrighty, perfect. We're gonna jump into the Q&A. So we have some ED questions that we're gonna jump into first here. And the first question we have tonight about ED. It's not really a review, but it's a good question nonetheless. Have platelet-rich plasma injections proven to be effective in treating ED?
That's a really great question. So there are, we just had our meeting, the SMSNA meeting, the Sexual Medicine Society of North America meeting actually last week. So this is, even though it says North America, we have the brightest minds in sexual medicine from all around the world at this meeting. There was a very nice talk given by Dr. Wayne Hellstrom, who is a giant in this field. He's at Tulane. And, what I would tell you about PRP is that right now, certainly as he suggested and as our American Urological Association guidelines recommend, is that this is to be considered investigational at this time. I think the biggest issue right now with PRP is that there are so many different machines and devices for this that we don't truly know what actually is in PRP, right? So PRP, platelet-rich plasma, is a very broad umbrella term. And while, the studies are highly variable, what I would tell you is that if it is going to affect anybody or help anybody, it would be for people with very mild erectile dysfunction, almost as like a, filling up to the brim kind of deal, not for a patient who has severe ED, either post-prostatectomy or, who has really bad diabetes. That's what I would say to that.
All righty, perfect. Next question here. Can my medicine for my continence be contributing to my ED?
Medicine for what?
Continence. It doesn't mention any specific meds, but general continence meds, I suppose.
Yeah, I would say so. In general, the answer is no. There are not really any recognized medications to help treat stress incontinence. However, we do have other types of incontinence, such as urge incontinence, which is related often to overactive bladder. There are a variety of medications, so like some really common ones would be ditropan, Myrbetriq, medications like that. And certainly there's no good data that links those medications directly to erectile dysfunction, from our standpoint.
Alrighty. Next question here is about tadalafil, and this person wants to know why their daily dose of 5 milligrams of tadalafil may be creating back pain, and how can they avoid this?
Yeah, that's a really good. So when we talk about phosphodiesterase 5 inhibitors or PDE5 inhibitors, so this is a class of medications. The most common two that we mentioned are, so tadalafil or Cialis, those are the same thing, or sildenafil and Viagra, again, the same thing. There are a few others on the market like Levitra and things like that. And, what we know about all these medications is that none of them are perfect, right? And so while the medication aims to inhibit PDE5 or phosphodiesterase 5, there are other PDEs, so PDE6, PDE11. And what we know is that these medications do have small amounts of cross-reactivity potentially to some of these other PDEs. So for instance, you may hear about people taking Viagra and having issues with their vision, right? Not serious issues, but sometimes they'll talk about the hue of their visual field is more blue. And that's because there is some cross-reactivity to PDE6. Cialis does not affect PDE6. However, it does have small amounts of cross-reactivity with PDE11, which can be a linker to musculoskeletal pain and back pain. So we do tell people that when they take Cialis, it is quite possible that they may have some kind of like dull back pain or myalgias. It's not dangerous. If this is something you can live with, great. If it's a side effect that really bothers you, I would potentially consider talking to your urologist or primary care doctor about switching PDE5 medications.
Alrighty, thank you for answering that question. Next question here, which is also a great question. Would you treat ED caused by long road bicycling different from other causes?
Yeah, so we talk about that. So here in my current practice in Chicago, we have a lot of gentlemen who are very, very avid cyclists. And, what the data will suggest is that so when we talk about biking, for those of you who don't know, so the bicycle seat can compress the perineal region, which is the area between the back of your scrotum to your anus. And that can very rarely affect the nerves that run in those areas and lead to some ED. However, it is exceedingly rare, and what we tell people and what the literature would suggest is that in order to have truly induced ED from that issue alone, you would need to be biking, I mean, somewhere in the order of 50 to 100 miles a week. So this is certainly for people who are biking very large distances. Otherwise, the risk of it is very low. What I would tell you, if I had a gentleman in my office who was like, you know, doing like Ironman competitions or biking just like tons of miles, like very good for their heart, maybe not so good for their perineum, what I would do first is I would want to assess how their erections are working, and we may consider something in the office called a penile duplex study, which is an ultrasound study to look at the blood flow to the penis, and that would help dictate how we treat you.
Alrighty, thank you for answering that one as well. We're going to move along to some post-prostate related questions. A few of these will be a review, but they're very important nonetheless. So first one here is, what is the maximum expected time after surgery, which one can determine that his incontinence needs to be seriously addressed?
This is a really good question and something we talk about all the time. So first and foremost, we want you to be well healed from your prostate surgery. Provided that you had a radical prostatectomy. Likewise, if you've had radiation, we want to give you time to heal. What I would tell you, so our American Urological Association guidelines, which are certainly not the end-all be-all, but do provide us with a good framework to provide good patient care, is that, you know, at minimum, we should be waiting 6 months to see if people regain their continence. At this point, we can start to consider things like a sling or surgery. However, what the data will suggest is that in general, most patients will reach their kind of best case scenario by 1 year. So that when we get to 6 months, that's where I have kind of a shared decision-making process with my patients about, you know, how much this is bothering them and how long they're willing to wait.
Alrighty, perfect. Let's see. So next question here. Why would removing the prostate cause leaking? I don't know if this, I believe this is could be venous leakage or incontinence leakage, but let's go with incontinence. And they are asking, is it poor or bad procedure?
So really what happens is, you know, when the prostate is removed, if you think about, so the prostate, so our pelvic floors, that is the musculature kind of in our pubic region. And what that does is that keeps all of the organs that are in our belly, in our pelvis and in our belly, up in our pelvis and belly. And the musculature surrounds the prostate. And certainly while I'm not a prostate cancer surgeon, this is something I did a lot of during my training. So I can certainly comment on, you know, the anatomy and the technique, having done quite a few of these. The goal is to remove the prostate in such a way where the pelvic floor is not being damaged. And, you know, certainly aggressive dissection or, you know, things like that can lead to damaging of the pelvic floor, which helps support the urethra for maintenance of continence. Similarly, the nerves, which, you know, work in that area, can also be damaged, which affects the ability for the external sphincter to work. Which is what's ultimately, you know, when we feel like we have to run to the bathroom, that sensation like I need to pee right now, that sphincter, that muscular sphincter is what's preventing us from leaking actually. And sometimes that can be compromised.
Alrighty, perfect. We are going to move along to some more surgery related questions, but these will be more so about the surgeries we just talked about tonight. So first question here, this person says, I'm allergic to nickel and I'm allergic to some antibiotics. Which should I test for if I want a penile prosthesis?
Yeah, great question. So we have a few different options for this. So as far as the nickel goes, that would not be an issue for the devices. In terms of the antibiotics, so the two, as I had mentioned before, the inhibizone, which is what makes that device yellow in nature, it's two antibiotics that comprise inhibizone. It's rifampin and minocycline. So for patients who have very serious allergies to either of those medications, Boston Scientific does make a non-coated, non-inhibizone device that we use in our patients who have allergies. The risk of infection from not using that device, not having the inhibizone, is only it's a few percentage extra, but it's a great and very safe option for patients who have allergies to those two drugs. So that would be something you would want to talk to your doctor about before receiving a surgery.
Certainly. Okay, next question here. Can bladder leakage and erectile dysfunction be treated with one or more treatments? I'm a prostate cancer survivor and I have both.
Yeah, so every doctor, this would be one of those where you would want to talk to your doctor about their preferences. Feasibly, so like let's say you wanted both a penile implant as well as an artificial urinary sphincter. You could technically receive those surgeries at the same time. However, in my general practice, we do not like to do that. We like to treat typically the continence first. And the reason why is when you receive an AUS, for the first about 4 weeks after surgery, as I had mentioned, your device is going to be deactivated, which means it's not compressing the urethral opening, and you're still going to leak urine. And that's okay because we want things to heal. But the problem is if there's an incision line underneath the penis, which is where we would go to place the penile implant, there is the risk of that leakage of urine getting on that incision and being an increased infection risk. So certainly in my practice, I do like to treat, the urinary leakage first before we treat the erectile dysfunction, or we have a talk with the patient about what's most important to them and the risks and benefits. But I do not prefer to do it as a combined approach.
Alrighty. Next question here. How does the size selection process work for a penile implant? Can you get more length during the surgery?
That's a really great question. So a very common thing you will hear me say in my clinic to my patients when I talk about penile implants, like before, we get a penile implant, we will do a thorough physical exam. And what I will do, we know that all men, unfortunately, I wish I could find a way to make this not true, but all men with age, especially patients who have had their prostate removed, will have some degree of penile shrinkage. So we have a very candid, very straightforward talk with my patients about what a penile implant can do for you is make you rigid, on demand for sexual activity. What I cannot, unfortunately, do is make your penis 25 years old again and make it, the same length that it once was. However, what is important about the penile implant is, so when we size it, so we do the surgery, and during the surgery, we have measuring tools that measure the length of the tissue in the penis called the corpora cavernosum. And what we do is we measure the exact length of that. And, our manufacturers have every size made. So we measure the length and we choose the device that is well suited for that length. What I can say and what I tell a lot of patients is, unlike other treatment options like medications, injections, where you will continue to lose length with time, from the moment your penile implant goes in, that is the length you will have. So I talk to patients about it preserving the penile length that they have, which I think is very important because you're halting that shrinking process. But unfortunately, I cannot make you bigger than what you have. What I often tell patients to do is take the head of their penis in front of a mirror, stretch it out as far as they can in front of them. That's called the stretched penile length, and that is a good surrogate for the length of your penis with an implant, but not the girth and rigidity.
Alrighty, perfect. Next question here, implant related. Can an implant help fix a slight Peyronie's curvature?
Oh, great question. So another thing that I treat a lot of in my practice is Peyronie's disease. So for those who do not know, Peyronie's disease is a very, very common condition present in about 15 to 20% of men, and prostate cancer surgery is an independent risk factor for developing new Peyronie's disease. What it is a curvature of the penis, and the answer is yes. So, for men who have Peyronie's disease but have good erections, this is not part of this talk, but there are other treatment options that we can offer, other surgeries we can offer, and that's certainly something I do a lot of. For gentlemen who have penile curvature but also are not able to get reliable erections, who want an implant, it depends on the degree of the curvature, right? So the penile implant in many patients will fix the curvature altogether. So the device is rigid enough that it will straighten you out. However, sometimes we put the implant in and we test the inflation in the OR before we finish surgery, and sometimes there's still curvature. There are a variety of techniques that we can do along with the implant that will help straighten things out as well.
Alrighty, perfect. Let's see, next question here. What is the typical time one should wait before considering an implant post-prostatectomy?
Right. So what I tell people is, so first things first, I think it's important to differentiate between patients who have had what's called a nerve spare prostatectomy and patients who have had just a standard radical prostatectomy. So this would be very important to talk to your prostate cancer surgeon about whether they're performing a nerve spare procedure. If they've performed a nerve spare procedure, I think it is very reasonable, and often what we do in our practice is to wait closer to a year to see how patients are doing. However, this is a shared decision-making process between me and my patients, and some patients, the minimum I would do an implant on a patient would be 6 months out from surgery, and that's going to be a discussion between us. But I do find for folks that have had a nerve spare procedure, waiting a year is best. For folks who did not have a nerve spare procedure, it makes sense to go sooner to preserve the length that they do have.
Certainly. Alrighty, we have a urinary incontinence question here, but this person wants to know, how will diabetes affect the solution options for SUI?
Oh, sure. So the biggest thing is that, so diabetes it doesn't really impact whether I would recommend a sling or an artificial urinary sphincter. What's very important both for penile implants and for urinary sphincters and slings is that one's diabetes be well controlled. And we define this in the prosthetic urology world as a hemoglobin A1C of less than 8, at least in my practice. Everybody's threshold is a little different, but typically 8 is a very common threshold. The reason why is because as people's blood sugar gets higher and that A1C gets higher, the risk of poor wound healing and infection goes up. So we certainly want your sugars to be well controlled to minimize that risk of infection.
Alrighty. Let's see, we got a couple more here in the implant section. So is the sexual sensation with the penile implant still the same?
Yes, very good question. So the nerves that control erections versus the nerves that control sensation and orgasm and ejaculation are very different. So we do tell people that their sensation, whatever they have sensation-wise to the penis before surgery, is what they have on the other side. So the surgery itself will not impact your sensation or the ability to have an orgasm.
Alrighty. We're going to jump to some questions in the chat. And this one says, does watching a lot of pornographic content cause ED? And is there a treatment for this? And if so, would this be a mental or medication?
This is a very controversial thing that certainly you will see on a lot of social media platforms and in the news. I think the way I counsel patients about pornography and sexual activity is that I do not personally believe pornography in and of itself is a bad thing. However, where it can become a problem for my patients or for my patients who are, utilizing this resource very frequently, and then that lowers the sensitivity, or that increases the sensitivity threshold, that it makes real life sexual activity and intercourse not as stimulating or exciting because they've already kind of done that for themselves. So certainly if patients can kind of differentiate like pornographic material versus like activity with a partner or with themselves without pornography, I think that's fine. Where it can become an issue is when it's taking priority over our real life relationships. And certainly that is something I work with my patients and sexual health counselors and therapists to help patients with.
Alrighty. Another question from the chat. Can a statin drug help with ED or hurt it?
Yeah, so what I would tell you is that, I had made a brief comment before that what's good for the heart is good for the penis. And I say that half jokingly, but I'm serious, because the arteries, the vessels in our body that supply blood, are the ones that go to the penis are very, very small. So if there is a process in our body like high blood pressure, diabetes, high cholesterol, things like that, that are impacting the blood vessels, they're going to impact the smaller blood vessels first before they affect bigger blood vessels like the ones in our belly and the ones in our heart. And so what I tell people is that if you know, I would counsel you, and I do, you know, I do this myself with my primary care provider, you know, have your cholesterol checked, because if your cholesterol is high, you know, being treated appropriately for high cholesterol is protective against the development of future ED. I would not say the drug in and of itself has been strongly linked to ED, but taking it can certainly help fix your cholesterol, which will help prevent the progression of ED.
Alrighty. We have time for a couple more questions here. So I believe this is a review, but it's a good review question nonetheless. So in general, what is the lifespan of the implants that we talked about tonight for IPP and ED?
Yeah, so that's a great question. So in general, what we quote people is that from the time you receive your penile implant, the 10-year device failure rate, so this would mean, you know, either a connection breaks or the tubing, you know, there's a leak somewhere in the system, the 10-year device failure rate is about 5 to 8% of patients. If that happens, no big deal. You know, the device gets replaced. But I think, you know, at 10 years, if only 5 to 8% are having device failure, I think that's pretty good. But it is not foolproof for sure.
Certainly. Very good there. Okay, this is a final question to wrap us up. I think it's a great question. So how do I best select a doctor to perform any of these surgeries in my general location?
Yeah, that's a really good question. So one of the things I would encourage you to do, so there are, you know, and certainly Boston Scientific does this, and certainly there's one other mainstay implant company in the country called Coloplast. If you go on their website, what you can do is they have tools that will help you find providers near you. So you can put in your zip code and it will show you a list of providers. And what you really want to look for, like for instance, if I or my father was having a procedure, what you want to look for is someone who is designated as a center of excellence. And what this shows is that this surgeon does a high volume of these procedures, because we know that patients who do higher volume of these, so people who are fellowship trained for prosthetic urology who do a lot of these surgeries, have better outcomes, right? So you do more of something, you're likely to do it better than the general urologist who does 2 of these a year, you know? So I would say go to the website, look at the providers, look who's fellowship trained, and look who has a center of excellence established.
If you'd like to learn more about the advanced treatment options that we talked about tonight, you do have a few options. You can learn more about these surgical options by going to fixincontinence.com or by going to the menmd.com website and navigating to the ED or incontinence condition pages. We also have links to all of the surgical options there as well. If you have any question that was not answered tonight, or you'd like to speak with someone in person, you can call MenMD at 857-233-5837 or log into the password-protected MenMD portal to schedule an appointment one-on-one with a personal health assistant. And there will also be more resources in the Resource Center on menmd.com. You may visit this page to view instructional videos, guides, expert articles, and more.
No, I think that's great. Thank you so much, Ashton. Thank you, MenMD, for having me. Hopefully this session was helpful for you gentlemen out there.
If you found this video helpful and want to stay in the loop with our growing men's health community, be sure to subscribe to our channel and click the bell to be notified when new content is available. Your support makes it easier for other men like you to find these helpful resources. Thanks again for watching. We hope to see you again.